This skill is direct orotracheal intubation of a pediatric patient. So I'm going to come up, BSI scene safety. I'm going to come up to the patient, assessing for responsiveness, baby, touching the feet, the shoulders, seeing if there's any responsiveness from the patient. I'm going to assess the patient's pulse, radial pulse. Look, listen, feel for breathing. I'm going to listen for breathing, looking for adequate chest rise and fall. Now I'm going to assess the baby. I note that it does need an airway adjunct, so I'm going to size up the appropriate size OPA. I'm going to open up the patient's mouth softly using scissor technique, insert the OPA at 90 degrees, rotating it in. Now I'm going to use the BVM to deliver supplemental oxygen. I'm going to deliver at least 12 to 20 breaths a minute. While doing so, I'm going to hook up my capnography to my oxygen cylinder. My life pack, sorry. It's still ventilating one breath every 12 to 20 times per minute. I'm going to hook up my my BVM to my oxygen cylinder with 100% oxygen, at least 85% to deliver supplemental oxygen to pre-oxygenate my patient before direct orotracheal intubation. So I'm going to continue to deliver these ventilations to my patient. Still using EC clamp to confirm that I do have a secure face to mask seal. So I'm going to continue to ventilate for about 3 to 5 minutes to pre-oxygenate my patient enough to then go into my intubation. So I'm going to deliver one more breath. While this point, I'm going to be talking the parents through normally at what I'm going to be doing. So I'll tell them, so I'm going to use this tube. I'm going to place it down your baby's trachea so that we can secure the airway and deliver the correct ventilations as needed. So I'm going to start that. I'm going to remove the airway device. I'm going to have all my supplies already ready, lubricated and everything. Now I'm going to use my laryngoscope and laryngoscope blade. I'm going to sweep the tongue to the left, lifting up, not depressing the teeth, making sure that I do not crack them or put any pressure on them whatsoever. So with my ET tube, I'm going to place it in the patient's mouth. I'm going to visualize the tube going through the patient's vocal cords, taking no longer than 30 seconds to place the tube. So I visualize the tube going past the vocal cords. I'm going to note the depth. I'm going to immediately remove the stylet. Now I'm going to hook the BVM back on to ventilate the patient, assessing for adequate chest rise and fall. So the depth is at 16 centimeters. Continue to ventilate 12 to 20 breaths a minute with my capnography hooked up. I'm going to ask my partner, hopefully I have my partner, to take over securing the airway device while I auscultate the epigastrium and the chest. So my partner's taking over now. I've got my stethoscope. Now I'm going to ask him to deliver a breath, listening over the epigastrium, breath. Now over the patient's chest, breath, breath. One more, breath. Okay, so I do not hear any airflow over the epigastrium, so therefore I know that I have intubated the trachea. I do see adequate chest rise and fall, so I know that I am ventilating my patient correctly. So I'm going to continue to ventilate my patient. I'm going to have my partner help me with securing the device to the patient. So I do not have a pediatric ET tube placement, so I'm going to use some tape and some gauze to secure it. So